Good morning, everyone.
Good morning.
Morning.
Hi.
Good morning.
Good morning. I see that we're still waiting on a few people to come in. Got about 83. Okay. Just a few announcements, things just to make sure. I want to make sure everybody knows. Next week is exam 4. The nursing club is going to be having a bake sale before class and after class till about 12:30. If anybody wants to bring in some baked goods to help, the money is going to go back to the class for events and things that we will be doing for our club next year when you guys are seniors. We are also going to be doing a so-called raffle, but we can't word it as a raffle. We're going to be calling it as a donation to the nursing club. And people will be able to win a prize at that time. So we will have all the specific details at that time. Yep, Robert is bringing Italian cookies. And so I'm waiting to try that, and I'm going to save my money for that day. The exam is the 3rd, May 3rd. Okay, so if anybody wants to bring in some baked goods or supplies, they can bring them in prior to the exam that morning. We're going to be in Founders Hall. Okay, and I'm going to. Yes, sir.
Can I just add that if anyone is bringing in donations, that they need to be individually wrapped. So you can't bring like a box of donuts or something like that, or any cookies or anything. Just need to be individually wrapped.
Yeah, and I can also try to remember to get us a bag of plastic bags and ties or something too. I'll put that on my grocery list just in case somebody does bring them in. We could I'm writing grocery list, not bags. And also, if anybody didn't get a chance to purchase apparel, like you see my nice Naugatuck Valley shirt, I sported it today to make sure I reminded myself it's also freezing out. When the incoming freshmen are going to have their orientation the last week of May, and we're going to be running another apparel sale. So if anybody missed the deadline for the 15th, we are going to run another apparel sale. And just as the other 2 apparel sales we held, the money will go back to the class for some of our various fundraisers and activities. Okay. Anything else you want to announce, Heidi, or while we have the class?
Not that I could think of.
No. Okay. All right. Perfect. All right. So then we're going to move on. Oh, the other thing, my session I usually hold on Mondays, I mentioned yesterday to study for exam 4. I'm going to move to this Friday after clinical about 1:45, I would say. Usually we'll stay on for about an hour and a half. If anybody would like to join in, I usually hold it in Collaborate. So I will post it. You have clinical all day. Carice, if you have questions, you can reach out to me. I just have a meeting for grad commencement study session. Yeah, I usually open up the Collaborate and students come in, ask questions, and I try to answer them. Students learn from each other. It's just a faculty guided study session.
Is this just for your material or is this for all material?
All material. If I don't know the answer, I will look it up and I will try to help you guys.
Thanks.
You're welcome. Okay. Although I do have for a good chunk of the test available. Okay. I didn't make the study session yet in the Collaborate, but you'll find it there. Okay. All right, so today we're going to talk about failure to thrive and eating disorders. I'm going to do failure to thrive first, just because it tends to go. We talked about obesity, where we have people who are overweight and what kind of complications they may have. And now we're going to talk about nutritional deficits on the other end of the spectrum, where either the infant or the person is suffering from malnutrition and far underweight. Okay. So the book kind of throws failure to thrive and geriatric failure to thrive back to back in the way they describe it. I'm going to try to go over some of the commonalities and distinguish between the two. The most the significant difference when you talk about failure to thrive or FTT versus GFT, the geriatric failure to thrive, is the difference in age. Okay. Typically, when you talk about failure to thrive, it occurs in infants and your younger children. And then the geriatric failure to thrive is a condition that happens when you're older. Okay, and there's going to be different factors that contribute between the failure to thrive, as you could expect. There's different issues when you're little, and then you've got different problems when you're older. Okay. But it's important to know the criteria is that we're talking about somebody who's significantly underweight or the making sure that we know that if they fall below the 5th percentile on the weight and height chart, the standard growth chart, or they're falling into the lower percentiles or failing to meet the lower percentiles on the growth chart, they stop growing or they're not gaining weight or not doing as well, is what the criteria is. So it's not just somebody who's, born small and well, they might be born small, but they're just not meeting the height and weight requirements for their group or their age group, I should say. Does everybody know what the standard growth chart is? I'm sure you've guys seen it in maternity. If not, yes, okay. I might have. It looks like this, where you find the weight, the age, and then the length and the age goes across the top. So when they fall below the 5th percentile, you want to look in the little, I can't even see it here, but they would fall far below. My son, who's really big for his height and weight, he's in the 100th percentile. So he's up over the chart, this is for birth at 36 months. You would see that after 36 months to whatever time, they will have a different growth chart. So that's what I mean by the growth chart. Okay. The most common cause for failure to thrive is malnutrition. There can be some other factors that do contribute to it. But there aren't a lot of statistics because, it isn't typically documented often or reported back. Okay. Another factor that may be used is the poverty rates. So people who fall below the poverty level will be at greater risk for developing this, the children born into that category. Okay. Whereas with geriatric failure to thrive, it happens in adult. There's a lot of different things that happen with the patient's ability to function physically. They have a weight loss of greater than 5% of their baseline body weight. They have decreased appetite. They're undernourished. They have dehydration and depression. One of the most common factors with geriatric failure to thrive is medication. Okay. So how does it happen? They're not getting enough calories. They may have trouble with inadequate absorption, right? So you might think of, a child who has a genetic problem. They might not be able to absorb the nutrients. They might have cleft palate or something and not take in enough nutrients, or they're burning more calories than they are actually able to take in. Okay. Chronic diseases, when you talk about your geriatric failure to thrive, having multiple diseases or chronic diseases such as cancer, inflammatory disease, disorders of the lung or kidneys may contribute to it. All right. Some medications that we also prescribe to them cause anorexia. Um, and anorexia, not the anorexia that we're talking about next, the anorexia nervosa, just anorexia meaning a lack of appetite. Okay. So, what is the cause? So, it can be in organic or non organic, right? Organic meaning that there's some inborn errors in metabolism with the absorption, AIDS, neurological disease, the cleft palate. And then another picture, I will show you what the cleft palate looks like if you're not familiar with that, or reflux. Okay. Non-organic means that there's an issue with feeding in infancy or early childhood. Okay. Changes due to geriatric failure to thrive, or changes in body composition, imbalance between energy and demand, homeostasis, trouble with dysregulation, or neurological or psychological problems. Okay. What does that mean? It means that the infants can have many risk factors, as well your older population. So here I put it in a side-by-side comparison so you can see what the common problems that may lead to failure to thrive. Okay. So a lot of it can be due to the relationship, or that bond that you guys learned about when you talked about in the mother and the baby when they're first born. What do? We try to do skin to skin. We try to have them form a relationship, so the mom and the child, or the father, as well, whoever the caregiver is, forms a connection, and that is very helpful for the infant. Okay. A lot of times, if a infant or child is born or has parents or caregivers who suffer from depression, and you guys learned about the postpartum depression, substance abuse, any cognitive impairment or psychosis, they might not be able to provide all of the care that the child needs. They might not be able to form that bonding that is so necessary. Okay. It can happen with social or emotional isolation, or not knowing exactly how much nutrients the infant needs. Okay. And then again, poverty. And poverty is also one of the same risk factors for geriatric failure to thrive. You think about it, after you retire, you might not have the income going in. People nowadays go paycheck to paycheck, so they don't have a lot of money to save up for after they retire. Things are getting so expensive that it may be even hard to just purchase the food, for the average person, never mind somebody who does not have the adequate resources. Okay. But the difference, when they're older, you're going to have chronic diseases, as I mentioned. Does everybody know what polypharmacy is? Yeah, okay. Taking multiple medications, right? And there can be interactions with medications. Medications themselves might cause the anorexia, as I mentioned. Issues with sensory perception, delirium, substance abuse, depression, social isolation. Being a widow puts the person at greater risks, or people who do not have family that are able to help them or support them when they get older. So what are we going to do to try to prevent this from happening? In the parent of an infant, we want to make sure that they know how much nutrients their infant or newborn should be receiving. We can schedule home visits if there's trouble with bonding or connecting. especially if there is any type of postpartum depression or postpartum psychosis. And other things we will see is that any child who might have some difficulties meeting milestones, may have some physical impairments or disabilities or things that are going on. They may also need nursing support to come in to support not only the mom, but to support and evaluate the child. I think there was a comment that came up. I missed it. Would checkups also be? Yes. So we want to encourage more frequent well checks or follow-up appointments to make sure that they're being evaluated, especially if they're losing weight. You're going to see typically when a baby is first born, they're seen quite frequently, within a few days after being born, within a couple weeks, because they need more vaccinations. And then you see them kind of at a 6 month, 12-month, and then as they get older, it tends to be every year for a well physical. At least that's what insurance will cover, so they may need to be seen more frequently if there are any issues that are identified prior to that. Okay, good point, Erin. With geriatric failure to thrive, we want to make sure that we are looking at all the possible causes that may be affecting the patient's appetite. Medications could be one, physical abilities to feed themselves. We want to talk to the patient about eating high calorie, nutritionally dense foods. Can anybody think of another thing that we might implement, or what would it be an example be of dense? Ensure and Boost? Yes. All right. TPN, they may start that if there's some reason that they can't eat or drink, but that's going to be IV. We want to try to give them foods in small, frequent meals that they can tolerate. A lot of times you might also see that they will give patients medication to stimulate their appetite. I've given like a pill of marijuana or something like that to stimulate them, to make them more hungry, to make them want to eat. And we also want to look at maybe any Miracapine. Is that what it is? Thank you. I couldn't think of the real name of of what it was. And Remeron, isn't that for sleeping? I'm not positive. I could be wrong about that one. The other things we could do besides encourage them to eat small, frequent meals, we can think about home meal delivery systems. Now they give it for appetite stimulation too. Thank you, Nicole. Home delivery systems, Meals on Wheels. You can also, set up, and it's great now with all of these delivery systems, such like Stop and Shop. It has Peapod. All these has in-home delivery. They can get the food delivered right to the house. Instacart, thank you. The trouble is sometimes you have to order them online, and the older population might not be as comfortable or familiar with being able to use that. There may be some uncomfortableness of adding their credit card or stuff online. So it might be a great thing that family members can do, is to set it up or make a visit and just ask what type of food that they need and have prepared meals, food delivered right to them. Okay. We want to try to make sure that they don't have any isolation or feel isolated from their friends, because socialization is something where you've always kind of met with your family and had dinner together. People who live alone might not say, "Oh, I'm not going to cook for just me," or "I'm not going to sit down and eat. It's just me." So having family visit if they can, for meal times. Support groups is very helpful, or getting them up and involved. And I think a lot of people mentioned these strategies while I read their Well Elder assignments. So that was really great that people had identified that. And if they are in the hospital, we can make arrangements with a case manager or social worker to help identify any type of financial issues that they may have, or transportation issues getting to the supermarket, maybe arranging for a home health aide, or somebody to come in and support them to do the light shopping for them, or find them the financial resources that they do need to get adequate nutrition. Okay, so how is a person, I should say an infant or child with failure to thrive, going to present? They're not going to eat adequately. They're not going to be taking in enough nutrients. And I know the old chain of the old beliefs is going to be, a child will never let themselves starve. Hear it all the time. As my son, who has trouble feeding himself, everybody's, oh no, when they're hungry they'll eat. But that's not necessarily always the case, because sometimes you don't have the physical ability, the attention to do so. And then other times, even if we have the willingness to eat, we might not have the resources or the food. Okay. So what we're going to see is no weight gain, or with weight loss in children less than 6 years of age. So we always are going to make sure that we do a height and weight at the visits, and check and see how they're doing. With the infants, there might not be any underlying physical disorder that can be causing the problem that they're having. They may have erratic sleep patterns. You'll find that they're irritable and difficult to soothe or condole. You will see a lot of times there might be some developmental delay, and they're definitely falling below the growth patterns as mentioned previously on that growth chart. With a geriatric patient who has failure to thrive, we are going to see unintentional weight loss, lack of appetite or energy. They're not going to be up and moving as much. They're not going to have the strength that they need. We're going to start to see muscle tone wasting away, limbs that are going to be cachectic, which means like very, very small and thin. When you don't have enough nutrients, your skin becomes dry, your skin starts to get very flaky. And keep that in mind, because we can build upon that when we think upon the nutritional deficits, right? What we talked about with our patients who weren't getting enough nutrients because of the bariatric surgery. We're also going to see that as another common thing in our patients who are suffering from eating disorders. So you can kind of combine some of the thought. There are some differences, however. All right. When we need to have good, adequate nutrition to heal our wounds, like we talked about when we talked about tissue integrity. So if they're not going to get adequate nutrition to heal these wounds, we're going to see that there is a delay in any type of wound healing that we have. You want to look at different blood tests, and this is very important for you to identify. And what is it going to look at? We're going to be looking at the height and the weight of the person. We could see, their BMI, how much, body mass, what their body mass index is. But we can also look at blood work, and that can indicate if the person is having issues with malnutrition. The most important one would be the albumin level. Okay. But we can see that it also can impact the hematocrit and hemoglobin and show that they're anemic, prealbumin levels, and cholesterol levels. Okay. We are going to see that the person almost appears that they are just wasting away, or very, very, very frail. All right. Has anybody had a patient who has been diagnosed with failure to thrive? Yes. Okay. And what did you see, or what kind of um how did they present, I guess I should say? Anybody want to unmute and share?
My patient that was failure to thrive, he had a wound that wasn't healing no matter what. And he was just quickly going downhill because he wasn't getting the nutrients that he needed.
Okay.
His skin was definitely suffering, though, specifically.
Okay. And was he eating? Did he need help eating, or what about medications? What other things did you see that might have contributed to this person?
He actually had cancer and the mass was growing. So I believe that played a role in him not having an appetite because it was in his stomach
Mm-hmm.
and it was growing into his neck.
Mm-hmm.
So I believe that absolutely played a role because he was in pain. He had thrush in his mouth. He had a lot of different things going on.
Got it. Yeah, but that falls into the defining character, the thing of having chronic disease, right?
Mhm.
Such as cancer. So that picture, that person fits the image very well. So thank you for sharing. Yeah, and
Yeah.
thrush makes it so you don't want to eat if you have trouble with your stomach. So these are all signs and things that you need to be, looking at. And I would imagine that they ordered some, and if I'm thinking of the right patient, Emily, I believe you did help feed the patient, making sure that they have Ensure at the meal time or between meals is another great strategy. So that way, after they eat, they can continue to sip on the Ensure, or not necessarily giving them just the Ensure, prior to eating. We wanted to let them try to have some other food, but if they're not taking in the food, at least that's one of the things we want to make sure that we offer first or try to get into that person. Okay. Excellent. Okay, so diagnostic test. We talk about the lab results that you should be looking at. Food diaries are helpful, so they can see just how much a person is taking in. You can assess the amount of calories that they have actually consumed, so we could see what they're taking. Um, if they have a physical condition that is making it difficult for them to eat, this is the cleft palate that I was talking about. There's you guys can't see my hand here again. You will see that there is a connection. Sometimes a part of the top of the mouth is missing or might be connected, and there is visible space between there, so it makes it very difficult for them to latch or onto the nipple or to suck on a bottle, right? So a lot of times they will be receiving tube feeding. That might be helpful until the repair is done. And so you'll see here what the child will look like after with the repair, where they close the gap and they actually make a separation between the nasal cavity and the mouth. So it's two separate spaces, as you should have. Other things that might impair a person would be an infant or a child would be a bowel obstruction. So they would have to go in and remove that obstruction as well. Okay. Elderly patients may not, probably won't be having an issue with the cleft palate because hopefully that will be resolved much sooner. But if we see that an elderly person may have esophageal strictures, which is a narrowing of the esophagus, they too may also have bowel obstructions for masses such as cancer or impaction from, being constipated. All of those things might need to be repaired in order for them to be able to eat again. Right? What are we going to do if surgical therapies aren't necessary? We're going to be thinking about what can we give them as a type of medication to help. A lot of times, there isn't any medication that they really will give to an infant for this. They're going to try to support them with, is it a feeding issue, or a lack of resources. That's what we're going to try to manage and do there, unless there is something going on. Otherwise, they may have reflux or other problems like that with that could be treated with medication, but it's not very, very common. The other thing you may see is if they, might need some nutrients prescribed to them or given, but that is not very common either. Some of the things that we are going to see in our older patient population is making sure that we replace the vitamins and nutrients that they need. So vitamin D, that might be contributed to, not taking enough vitamin D in. We need that also, right, to break down our calcium, like when we drink milk. Vitamin B12, a lot of times, if there's an issue with absorption, they will give an injection. So you will see, and that's how you know it's B12. It's a bright red color. They can give it orally if they can absorb it. Otherwise, they will be giving them regular injections for that. Patients might be given antidepressants if they are suffering from depression. A lot of times you will see people who normally take these medications get weight gain as a side effect. So that is very helpful. Sometimes when you're depressed too, you just don't feel like eating. So if you can improve their mood, that may also help. Non-pharmacological treatments, again, this is probably what you're going to see more so, is educating the caregivers on nutrition, especially for the caregivers of infants and children. Home care visits will be good for both the infant and the geriatric failure to thrive. The one thing with the infants, we're going to talk about breastfeeding, and what we could do is, as you guys talked about in maternity, is making sure that the mother got adequate milk supply, that the child is taking enough, and that they're not having any trouble with the latch. And so the visiting nurse, or there can also be a lactation nurse that comes out and supports the mother, or the caregiver, I should say. Okay. We want to make sure that we improve oral intake. Sometimes offering the small frequent meals or making the portions a little smaller might be helpful. Sometimes if you give somebody a big plate of food, it can seem overwhelming to them. So maybe just offering smaller portions more frequently throughout the day. If anybody has trouble with dentition, making sure that they do see a dentist if they need to, that their dentures fit. One thing that we see, right, is anybody taking care of a patient who has lost a lot of weight, their dentures don't fit anymore. So they flop around and it makes it very difficult for them to eat. So if we notice that a patient has lost a lot of weight, one of the things that we might want to make sure we follow up on is making sure somebody gets them to the dentist to be reevaluated to see if they need new dentures. Other thing, they might have cavities or eroded teeth that may be sharp and uncomfortable for them. We want to provide snacks. And the other one, and the last thing seems kind of simple, but I often see that it may not be done very often, is provide meal choices that the patient actually wants. Just taking the time to sit with the patient, it takes a minute or two, but helping them fill out their menu with things that they actually want to have is very, very helpful, because a lot of times, especially if they're in the hospital, the tray just comes to them and they're like, I would never eat that at home. Well, what is it that you want? Maybe we can get something special, or maybe we can have the family bring in food from home if they don't have any dietary restrictions. So that might seem like a very simple thing to do, but you see now that a lot of hospitals have people that just go from room to room to room to ask them, can I help you fill out your menu? What is it that you would like to have? What kind of choices, or what can we bring? And I also love to see when a patient doesn't want to eat something. A lot of times my students will be like, okay, well, what would you like? Let me call down to dietary and see if we can have it brought up. They also have a lot of they usually have a nutrient kitchen where they keep, ice cream or Italian ice. A sandwich or two might be extra or left there, but we can go and grab them something for there if we cannot get it onto the meal tray or delivered up to them. Okay. All right. And I forgot who said, Maria, this is where the TPN comes in. For your patients who are critically ill, they're the ones who may need the enteral feedings. Long-term solution may be inserting a G tube for either of the patient if we can't get them the nutritional intake that they need. Okay. All right. What is our job as a nurse to do as far as the assessment? We need to do all of those basic objective collection of the data. We need the height, the weight to figure out their BMI, figure out their percentiles for the younger population. We want to keep track of, are they meeting their developmental milestones? Are they interacting? That's all important for us to identify. So we need to know, and this is where your developmental psychology came in, is to figure out what are the milestones, what should they be doing at an appropriate time in their life. Because if we don't know, then we don't pick up early enough that they aren't meeting those cues. Maybe they're not sitting up enough. Maybe they're not able to eat or do all of the things that they should be doing at their specific age. Okay. All right. And we want to not only assess that, but we want to teach the parents, what should the child be doing at this time? We don't want to compare a lot of children to one child to the next, because then that can be discouraging to the patient. But we do want to offer the parents a range between 3 to 6 months they should be doing this. By 6 to 9 months they should be sitting up, or they from 9 months to a year and a half they should be walking. So providing them some guidance, so that way then the parent knows and they can say, oh, you know what, my child isn't doing this, my child isn't doing that, because it can be hard to pick up on these delays if we are only spending a short period of time. And if the parent doesn't know enough to identify this as a delay, it can be challenging. Okay. It's important to identify what kind of stressors the parents have in their lives. Because if they're worried about, financial issues, work, or time, you can tell when somebody is very tense. And the infant or newborn can also pick up on that. All right. We want to know how the pregnancy was. Was it complicated or uncomplicated? Vaginal or C-section? Were there any other things that had happened? And how was that child's health when they were um, born? We also want to make sure that we observe the relationship between the parent and the child. Looking for cues. We talked a lot about abuse or neglect in another lecture. But we also want to make sure, do they, interact appropriately with the infant? Are they rocking them, singing to them, talking to them? And your nonverbal cues are going to be very important for you to be looking at. Is that parent comfortable with handling their child, right? I remember the first day they gave me my son, and I'm like, oh my God, I don't want to hurt him. I don't know how to handle him. But at some point, you start to becoming very comfortable. You start handling them. They're not going to break. They're much more resilient than they have, and you just develop a different comfort level. And I remember the pediatrician, with the first couple appointments I went, I had 2 diaper bags. My son would vomit a lot. I had bottles, feeding, diapers, extra set of clothes, you name it. It looked like I was moving in. And it was the funny thing that she said, I'm looking forward to the day that you can come in here with 1 diaper bag to know that I mastered it and I became comfortable with that, right? Is that a parent laughing? Somebody who's also done that? I know I feel now I keep an extra set of clothes or something in the car just because I have that. But before I remember packing like I was going on a field trip or, a 6-day venture to the Sahara Desert with all of the stuff that I would pack. So you can tell when a parent becomes comfortable in their role. All right. You have extra outfits for you when they vomit on you or for them? Because I had to have both. Both. Yeah, there you go. All right. Yes. Now, that is something I have. My son has an issue with getting wet. Like just a little spill is a sensory thing. So we always have extra clothes too. Or dirty. All right. Assessment for our elder population. We want to make sure that they're socializing. And that's something that you guys can do now as well. I see it all the time, and it makes me really happy to see students go into the room and just offer to feed a patient, even if it's not theirs. Because a lot of time there might be 1 or 2 aides on the floor. They can't be everywhere. So, I think we can start with every time we could do one little thing to make one little difference. That might be the one meal that patient had because you guys took the time to stop and talk to them or have a conversation with them. Has anybody had the opportunity to feed a patient? Oh, yeah, hopefully. Yeah, okay. And what were some of the tricks of that you guys picked up on making sure that they ate or get them to eat a little bit more? Cutting it, following their lead, their pace, small bites, allowing them choices. Yes.
And the campaign began after a ruling by the Italian Supreme Court.
Okay. Does somebody want to share something, or did they just unmute themselves by accident?
Justices felt that since the victim was wearing tight jeans, she must have helped the person who assaulted her remove the jeans, thereby implying.
Somebody want to share something?
Sorry.
That's okay. Didn't know if you wanted to say something, Sam. All right. The other thing we want to make sure that the room is nice, and I'm not talking about candles and all of that kind of stuff, but thinking about making the environment in the hospital pleasant, removing the bedside the urinal for the bedside table, washing the table down, removing all the type of clutter, and trying to make it a great environment. If you also have the ability to work as a home care nurse, we want to we want to take care of that. Okay. Kim, I had a patient in alcohol withdrawal. I didn't need necessarily to feed her, but I encouraged her to eat to help the low sodium out. Yes. So patients with alcohol withdrawal, they're going to have a new, we had that, I think a patient with that experience too. Substance abuse, a lot of times what you will see is, they might replace their meals with alcohol or taking in a substance, so they might not be getting all the nutrients that they need. Sometimes if they are impaired, they might not remember that they need to eat, right? So yeah, James, thank you. Oxygens and candles do not mix. That's funny. I laugh. But my dad has an oxygen tank, and I went in the other day, and my mom had gotten Yankee Candle to burn, and I'm like, oh God. So I got them one of those fake flutter candles. All right, nursing diagnosis. We're going to be thinking about imbalanced nutrition, growth delay, and risk for impaired parenting. So a lot of that, when you think about your children with failure to thrive, it's going to be a lot about that growth and the development, that relationship between the infant and the parent. And when you think about the older population, fatigue might be appropriate and balanced nutrition is going to be the same. And a lot of times self-care deficit. And I think somebody had talked about a patient, I think it was Kim who talked about a patient yesterday who wasn't able to do a lot of things for themselves. So you can see how if a person cannot care for themselves, make the food, go shopping, or to do all of these things, it's going to impact them. And one of the articles for the Well Elder also had to do with COVID. How did the COVID impact the elderly population? And it's mindful, they weren't able to go, even if they could shop, they weren't going out to get the things that they need. And still now, I think a lot of elderly people, or older people, I should say, are still nervous to go out in shop or to do the things that they need. So that's another risk or another thing for you guys to think about with failure to thrive. All right. So the goal, make sure they couldn't get the delivery service because they were overwhelmed. Yeah, I know it was taking weeks sometimes to get, Peapod or out there. And a lot of nursing, visiting nurses didn't necessarily like to go out to the house, or they didn't want nurses to come in, because you think they're going from one person to the next. That's not the person you want to come into the home. If you weren't even going to allow your son or daughter or family member to come visit, we sure as heck didn't want outside or strangers come in unless we necessarily had to. Okay, so we want to plan to see how is it that we can improve the parent-child relationship. How can we ensure that this child is getting the nutrients that they need? All right, and then with the geriatric population, we want to think about having them pick nutritionally dense foods that we can include in their meal. Sometimes as we talk about, the patient has depression, they may need some mental health appointments, somebody to support them, social worker, case manager, and then have meal supplements. All right, what are we going to do? What kind of nursing actions? We're going to monitor the height and weight for both of these populations. We're going to make sure that they're meeting their developmental milestones. So they're going to those well appointments, being seen more frequently. And a lot of times too, even if we are just questionable, you might see a pediatrician ask or have more frequent appointments than they need to, just so they can lay eyes on a child that they may be, suspecting will have some issues or stuff and use that as a reason to evaluate them. But that can also be the opportunity where they will see if any type of neglect is occurring and does a DCF referral need to be made, or birth to 3. Okay. Or home health services. With the elderly, height, weight, you're going to keep an eye on that. We want to monitor the intake and output. And we want to work with the pharmacist and the doctor to look at their medications, look and see what kind of medications might have anorexia as a side effect. So when you're doing your medication list, that's one thing you want. Your patient is, underweight, and they're not doing well, they're not hungry. Go and look up those medications and see, is anorexia a side effect? Maybe we can change that to a different medication. Maybe we can add a medication that's going to want to spark their appetite. Okay. If a patient is in a nursing home or assisted living, those social activities and those things that they have are great, great activities. Bringing them down to the dining hall. Some of you may go work in a nursing home and see that these people are, choosing to sit in their room and staying isolated. Getting them out and directing, saying to the aide, hey, why don't you go ask Miss Smith to come down to the dining hall, or have them, develop friendships or go to do the different activities and the social events that they have. Okay. Evaluation, we want to make sure that the child is starting to show improvement, gaining weight, starting to get above that low percentile on the growth chart. We want to make sure that the relationship between the parent or caregiver and child improves. And then we want to make sure that the child is, maintaining the weight as well, and we don't see that they're getting even more malnourished. Okay. Okay. And we want to make sure that they aren't developing any long-term complications from having failure to thrive. All right. We want to make sure with the elderly patient, they have food available to them. We have resources to help them get what they need, and the social support systems. All right. Any questions on failure to thrive? I know I did it rather quickly, but I think we have one more hour to cover. Hints. Yeah. Well, the criteria is important for the development, and you want to be able to recognize the clinical manifestations for failure to thrive. How is your patient going to present? And then the most important thing is, as a nurse, what is it that we're going to do for these patients? So assessments and interventions is going to be critical. As you know, we ask questions about analysis, looking at the lab values. How do we identify that this person might have failure to thrive? Because we don't have Post-its on our chest that says I have failure to thrive. So you need to be able to, pick up on it and look at your patient. As Emily did, her patient had the diagnosis already of failure to thrive. But, if that patient didn't have that diagnosis, would you be able to recognize, what was this patient's weight before, looking at their weight, identifying what their BMI is? No, you will not necessarily need to be able to read growth charts for them, but you should know what is an abnormal reading, and can anybody tell me what falling below the 5th percentile for height and weight, right? Yep. And then they're falling below the milestone significantly on that curve. All right. If there are no other questions, I'm gonna move on to anorexia. Do you guys need to take a bathroom break? Yes. Okay. Well, we'll start back at 10:30. Okay. Go stretch. And I think it's on where did I go? Did I go to the did I pass one? Right here. The development of our personality. And you might want to just review the chapter if you don't recall, how Sigmund Freud thought that these how we are treated, or all of the different things that impact us in our life can impact us on an unconscious level, and help to make us who we are, and how we develop our sense of self. Erickson, he thought culture, society can influence a person's personality, and a person can actually have crisis or have trouble with that sense of self, as a person grows, if these certain stages and norms do not happen or occur. All right. So the reason why it's connected into this topic of eating and feeding disorders, because when we have difficulty with self-concept, self-esteem, and self-awareness, it can lead to the development of feeding and eating disorders, and may also have some semblance of a personality disorder. And we're not going to go into personality disorders this semester, but you will get that next year. So that's why the self concept is kind of brought up really quickly. Okay. Moving on to eating disorders. In the past, it has been called, a person may have an eating disorder. They have since changed that. So you will now hear it as feeding and eating disorders. Okay. A lot of times we forget that adolescents may be impacted by this, but they're going through all of these changes of identifying who they are. So it is more common in adolescents and young adults. There's more prevalence of bulimia nervosa in the Hispanic adolescents. Anorexia nervosa is more prevalent in the non-Hispanic or white adolescents. And bulimia nervosa is more common than anorexia. All right. You may see that it may also impact lesbian, gay, bisexual, other people, in whether it be male or female, in high schools. Okay. All right. What are some of the risks? One of the things that you will see is that girls are more likely, almost 2 times as much, to develop an eating disorder. It's not to say that we shouldn't be assessing, males as well, but it is more common, is what it's saying. Okay. Research shows that there may be some genetic connection between developing these feeding and eating disorders, and it can be connected with personality disorders such as paranoia, delusion, or schizophrenia. So you want to evaluate or assess the person's mental health as well whenever we suspect that there might be an eating disorder. One common thing that we will see, and as we talked about in violence or trauma, any a child who has been a victim of trauma or sexual abuse may develop a personality disorder, or may be at greater risk for having poor self-esteem, and may be at greater risk for developing an eating disorder. Okay. Thinking about feeding and eating disorders, as we talked about, we need food. Our body needs nutrients in order to meet the requirements for metabolism, thermal regulation, and cellular regulation. All right. Eating disorders may come from societal pressures, things that might happen culturally, or how we, or other psychological issues. We can also have metabolic problems, such as that we talked about. And that should be that. Pathophysiology. There may be some biochemical or a neurotransmission or signal paths that cause some disruption or problems. It may be genetic. Puberty may have some role in that. All right. So when we think about the causes, it could be genetic or neurotransmitter dysfunction or cognitive behavioral. Feeding tends to be seen as a learned behavioral, and you can actually develop some irrational thoughts or beliefs about food, or you have some abnormal thoughts about your own body image. Okay, what are some of the risk factors? Genetic is going to be a non-modifiable risk factor. Cultural plays a good component of how men and women view their body. And then family factors, what's going on in the person's environment and in their home, in their childhood, or their the day-to-day life as they're growing up. Oh, I think I missed a slide. Prevention. We want to try to reduce any negative risk factors if we can. Talk about, body image. If somebody is suffering from poor self-esteem or depression, we want to try to, work on that with a patient, so they do have a more positive perception of themselves and their appearance. We want to try to, make their environment as positive as possible. Maybe get a social worker in, some family support, things to help within the family dynamics. School is another place where we can support, the younger children, making sure that they have good eating habits, making sure that they are forming good relationships and a good sense of self. Okay. As I mentioned, do you guys know what the DSM is? I want to make sure.
Yes.
Yes. Okay. All right. Good. Kind of. So in the medical, billing and stuff, a diagnosis, you can be classified according to ICD codes. So that's the code that they have. So one disorder, if you have diabetes is going to be code 1234.5. That's how it's submitted, and that's how they know, the insurance company knows what the diagnosis is. Within the mental health criteria, they go by something that is known as the DSM. And they are now on the 5th version of this. And the DSM identifies specific criteria for you to say that a person meets the specific criteria. And I think we talked about this when we talked about anxiety or depression in the past. In order to say that a person has anxiety, they have to meet X amount of criteria out of the 5 or 6 choices that we have. They have to have has to be ongoing, or they have to show signs of withdrawing from activities that they like, trouble sleeping. All of those criteria are evaluated by the healthcare provider, and then they diagnose them, and so they would then give them this specific diagnosis. Does that make more sense? With the DSM, so the ICD, with a medical diagnosis, they're going to be using the ICD codes. With the mental health, they're going to be using the DSM. It's very similar. but they're used for different things. Okay. Within the DSM-5, the feeding and eating disorder is got to be considered to be persistent disturbance in eating and eating related behaviors. Okay. This is different than somebody who might have a temporary change due to a traumatic experience or having suffering from substance abuse. Okay. The DSM-5 recognizes several eating and feeding disorders now. They are anorexia, bulimia, and binge eating. Those are the top 3 most common eating disorders, and those are the ones that we are going to review and that I want you guys to focus in on. But there's also pica, rumination disorders, avoidant restrictive food intake disorder, and other specified eating disorder. And note that obesity is not considered to be a feeding and eating disorder, although it probably should be. It's just not recognized at this point in time. Okay. So what is a feeding and eating disorder? It's a chronic disruption in eating and the behaviors leading up to, around eating, I would say, which impacts the way that you take in an adequate amount of nutrients. All right. Some of the causes, again, is low self-esteem. And that's why I had mentioned the concept of self-hatred, and fear. Physiological problems may develop by having a feeding and eating disorder, and may have some comorbidities with your mental health issues, such as anxiety, depression, substance abuse. Okay. And a lot of times people don't realize that the severity of these feeding and eating disorders, that they can be fatal. If you're not taking in adequate nutrients or doing some of the behaviors that go hand in hand with these disorders, can put somebody at great risks. Okay. So the first one we're going to talk about is anorexia nervosa. So as we mentioned in the previous slide, anorexia, is, not wanting to eat. That's just a medical term. This is going to be a diagnostic term, anorexia nervosa. And in this condition, you restrict your food intake. And so you're not meeting the nutrients that you need to be able to sustain your life. Okay. A lot of it happens because of the distorted body image and an intense fear of gaining weight. Okay. A lot of times it may be due to societal or cultural pressures. A lot of times, you see growing up, everybody wanted to be the Barbie doll. And I think now there's a lot more awareness and body shaming and acceptance of being overweight or being who you are, which I like to see that, and I'm glad to hear, because it can be challenging to meet the typical or what the society views as pretty or nice. All right, it can be potentially life-threatening. And some of the things that you will see is that patients who have anorexia nervosa diet or to the point where they're super, super thin and they're exercising excessively so they do not gain weight. One of the things we typically see is that it begins in your teenage years. And as I mentioned, it's more common in Caucasian females. Not to say that it can't happen in other patients, just saying that this is statistically where you see it more so. Within the DSM-5, we have to meet the diagnostic criteria to be able to diagnose a patient with anorexia nervosa, all right? The one thing I would say is your role as a nurse, you are not going to be diagnosing the patients with anorexia, right? This is going to come from a medical personnel, but I do want you to know what some of the criteria is, just so you will be able to identify or to be able to help your patients, or get them the support or a referral very quickly. Okay. The person must have an intense fear of gaining weight, refuse to maintain a healthy weight. So they know that they are underweight, but they are, are still choosing to, restrict their food or exercise, in order to, to meet that healthy weight, or that, where we would say that BMI that is appropriate. Another thing, they will have a distorted body image. So when they look in the mirror, what they see that they are still, they would say, oh, I feel fat. I don't like what I see in the mirror. And the reality, and I took the picture out of this slide, and I wish I had left it in, but you can have somebody who's very cachectic and emaciated, but when they look in the mirror, they still see that they are overweight, and that's what they actually see. In the past, in order to be diagnosed with anorexia, a female had to lose or have an absence of a menstrual cycle, and that has been removed. Okay. Other behaviors, limiting food consumption. Sometimes you may see that they vomit after they eat. They won't eat in the presence of other people. They use diuretics, laxative, and diet pills. Or they cut the food into small pieces and pretending to eat. Okay. So what do you think? You guys talked about diuretics, right? In the past few lectures. What kind of complications might develop when somebody takes diuretics? Yeah, hyponatremia, hypokalemia, dehydration, right? So these are all things that might lead to somebody having a cardiac issue, with their potassium level being too low, the sodium level being very, very low. So those are things that we always want to check. So if we think about that, we want to identify, are they using diuretics, laxatives? Laxatives, you're going to think about your patient who has had persistent diarrhea for a long period of time. What are they losing when they go to the bathroom so much, right? Same principle here. So this is a picture in the corner here of somebody who is so skinny. They are actually, you can see the bones in their body. They have no subcutaneous tissue, right? Other things that you're going to see, and this is important to know what clinical manifestations a person with anorexia will present in, because a lot of times they're not going to tell you. They try to conceal that they are not eating the way that they should, or how they're feeling. But it's going to be by looking at their hair, their nails. They come very brittle. The skin becomes dry. You might also have that yellow or jaundice appearance to it. And one of the things that is very common, does everybody know what lanugo is?
No.
No. Like,
Has to do with hair.
like hair. Yes, the babies, right? That's important to go back and get that from your maternity lecture. When the baby is first born, they have that very, very fine hair on their skin. So you will see that lanugo will start to form on parts of the body where they normally didn't have hair. So if you ever, get up close to somebody who you're like, oh my goodness, they are so super thin. If you see the little fine baby hairs as you would see on the baby, that will be there. And drug addicts, right? Yeah, because they take in food. They don't. I'm sorry. They take in more substance than food. If they had a choice, so you will see that in substance abuse as well. Yes. Starvation. Why with substance abuse do they? A lot of times, if you're on have a limited amount of money, and they tend to use their money to buy drugs or alcohol, right? They may also, suffer from anxiety or depression and not be taking care of themselves or not eating. Some of the times they can actually have nutritional deficits as well due to the substance abuse.
Why does the hair form though?
Oh, why does the hair form? I'll look that up and I'll let you know about that one. I'm not positive. Hold on, hold on 1 minute. To insulate. Thank you, Anna. Yeah, eating the disruption in body temperature when there isn't enough fat. Interesting. Yeah. So your body's trying to put like a protective mechanism there. All right. May constantly feel cold, and that's like if you think about your elderly patients as well. They start to lose that subcutaneous tissue, right? That's what keeps them warm. So they're always going to feel cold. You'll see. They also will put on a lot of clothes to hide their appearance underneath as well. Okay. Starvation can cause brain and kidney and heart damage. You will see that the pulse rate will drop as well with the blood pressure. You're going to see a lot of irregular heart rhythms develop, and that's where you could see that it could lead to a fatal event. They have brittle bones and changes in the brain because of the lack of nutrients, right? You will also see that there is a high suicide rate due to, the underlying mental health issues. Anorexia nervosa goes hand in hand with depression, bipolar disorder, anxiety, withdrawal. You will see that they may have some obsessive compulsive behavior as well. The one thing that I want to make note is that because of that distorted body image, a lot of things, what do you, I want to make sure we talk about that in the management of them. I don't know. About treatment. I'll talk about it now just so I don't forget to say something about it. So what are some interventions? How are we going to, help a person who has anorexia? What do we think as a nurse? What are some things we would want to do for this person? Group therapy, yeah. Collaborate with a therapist, counseling, mental health, yeah. What about your nursing assessments? What is it that we need to watch? Get them to eat slowly. Support groups. Vital signs, nutrition, intake, output, weight. Yep, monitoring. So Ryan and I think somebody else had mentioned it. I didn't catch the name. Suicide assessment, exactly. Electrolytes. Those are important things. We want to make sure we are weighing our patient we don't necessarily need to focus in on the weight or emphasize, you know, how they are doing, but it is very helpful to provide them with very objective information. Your weight is this. You know, you will see that a person with any with anorexia, they're weighed daily at the same time with the same clothes at the same time using the same scale. So that way they don't have any other reasons to say, oh, it's my shoes or it's something else. That's why I didn't do that. Electrolytes are critical because we are going to have hyponatremia, hyperkalemia, all of those things that can cause cardiac dysrhythmias. And then, as Rebecca said, the suicide assessment is going to be important as well. So those are great, great things that you said. We want to watch them eat, you know, and we want to watch them after they eat, so that way that we know that they are not vomiting after. We want to try to get them to eat with other people if possible, instead of just going into the room and eating in private, because they may not actually eat. Okay, we have about a half hour. Good. Bulimia nervosa is also a eating disorder. With this disorder, people are binging on food, or they overeat large meals because they feel a loss of control. This also has some mental health component to it. A lot of times, though, after you eat large meals, you start to feel bad about yourself, or guilty for eating the food, and then they will go and purge. Does everybody know what purging is? Vomiting after they eat large meals. So the difference with anorexia, they're not taking in the food, and then they may vomit and use these laxatives and diarrhea. With bulimia nervosa, they're eating and taking in a lot of food, and then they vomit and use laxatives as well. Okay, people with bulimia nervosa may have anorexia as well, but you will see that they are obsessed with their body image, and they are using the purging as a way to control their weight, right? The diagnostic criteria within the DSM-5 for binge eating is it must be unhealthy compensatory behaviors at least once per week over a 3-month period of time. So it has to be an ongoing thing over the 3 months, not just a temporary, oh, I ate too much and I'm going to go, vomit. And, we've all had that where we felt like we ate way too much at, Thanksgiving or something else. And we might be like, oh, I got to get this out of here. And have the compensatory behavior such as purging, excessive exercise. Okay. Underdiagnosed clients, what that means is that a lot of times we don't pick up, or the healthcare provider doesn't pick up on the fact that somebody has bulimia nervosa because they are of normal weight or even overweight. Okay. Whereas in your anorexic person, you're going to see that they are very, very much underweight. Okay. Typically, heart starts in late adolescence, your teenage years into adulthood. A majority of the people who have this are female, as opposed to about 10% are males. All right. It occurs in about 3% of our population, so it might not be quite as prevalent as our, obesity there, but they tend to go hand in hand with your mood, anxiety, substance abuse, and other self-injurious behaviors. Aaron, you wrote they're important to note that these patients will go at any length to let you believe that they're eating and getting better, right? That you're referring to anorexia, right? Yes, yeah, exactly. All right. I'm sorry, I just saw that it popped up now. All right. with bulimia nervosa, they may have it along with binge eating episodes. And binge eating means that they consume a large amount of food with a feeling of lack of control, and then they will use the vomiting, laxative, fasting, excessive exercise, right? This too goes hand in hand with depression, bipolar, anxiety, personality disorders, impulse control issues, substance, and has a greater risk of suicide. Okay. With bulimia nervosa, when they do have the purging, you will see that they will induce vomiting, right? They can use enemas, diuretics, laxatives, excessive dieting, and they tend to almost do it ritualistically, like on a regular basis, that they will start to purge just to feel a sense of control. Okay. It can be very dangerous. Other things that you will see, insistent about, indicators. How are we going to know that this person has bulimia? What are we going to look for? What are some signs of that? We want to be watching for a patient who goes and eats a large quantity of food. We say, oh wow, they ate a lot, and then they often leave and they say, oh, I got to go to the bathroom, I'll be right back, or I got to go do something, and they take off and they go to the bathroom and they're actually vomiting after they eat. You will see that they use syrup of ipecac. I think you might see that a lot of times in overdoses, or the charcoal. They give that to induce the vomiting, and it causes them to do that. Another thing that I've seen that it will induce vomiting, and they might do is drinking peroxide. All right. We will see that if it's a female patient, they will have menstrual irregularities, not necessarily amenorrhea or a complete loss of their menstrual cycle, but they may have some irregularities. Depression, you're going to see stomach pain, sore throat. A sore throat may be because of the frequent, vomiting and the gastric contents coming back up. The other thing that we want to look for is their dentition, because they may have damage to their teeth from the decay of the stomach acid on their teeth. You will see scarring on the back of their fingers from actually using their fingers to gag themselves, and swollen cheeks. All right. You will see that when they do use syrup of ipecac, it can cause cardiac arrhythmias, low blood pressure, heart failure. And again, you're going to see electrolyte disturbance. You might see a lot of bloating. So you want to do a good abdominal assessment, and listen to their bowel sounds, because the peristalsis, or that movement, may be very, very slow. Okay. Binge eating, I think we talked about that already. Binge eating without the purging is, these patients are sneaky, sneaking around trying to conceal that, but they are also eating when they're not necessarily hungry. All right. You will, again, just as bulimia nervosa, you will see that these patients are not diagnosed as often as they should be, because they appear to be of a normal body weight, and sometimes overweight or even obese. Okay. The one thing, the difference between binge eating disorders and bulimia is that it's not associated with an inappropriate compensatory behavior. All right. What do we see? They may eat a lot of food after they are already full. um, may be embarrassed or ashamed by the behavior that they have. Um, Initially, they feel good about eating, but then they tend to feel guilty about doing that. Again, body image is going to be a big component of this. Okay. There aren't a lot of tests that are specific diagnostic tests to determine this. So it's going to be based a lot upon your physical assessment. Okay. It can lead to high cholesterol, diabetes, and heart disease as complications. All right. Again, low self-esteem, depression, anxiety, bipolar disorder, and impulse control and substance abuse. So you will see that most of these three big eating disorders does have an underlying mental health issue, right? Is that clear? All right. The next couple of slides, I'm just going to go over, you can go over them we'll go over them relatively quickly. These are not going to be something that I want to make sure that you're accountable for the testing purposes, but something that you should be aware that does occur. Nocturnal sleep related eating disorders, initial period of insomnia followed by sleepwalking or semi-conscious state, in which the person goes and consumes food or non-food items. Okay. So they may not even be aware that they are getting up at night and eating. I don't know about anybody else, but I know when I don't sleep at night, I always walk to the refrigerator whether I'm hungry or not. All right. Typically more common in women, starts in their 20s. Often occurs in individuals with restless leg syndrome and may be linked to other is it brother BIL has this? Is that brother-in-law? I'm guessing. Yeah. Do you want to share anything about that? How does he present or?
He just gets up in the middle of the night and eats the weirdest stuff. Like he'll make a huge salad and pour milk all over it. So he's consuming, an entire head of lettuce and half a gallon of milk.
Oh, is he aware that it's happening?
No, has no idea. Till his wife says, "What the heck were you doing last night?"
Yeah, and they see the mess, right? And the plates in the fridge. Yeah.
Crazy stuff. Stuff in the refrigerator that should be, in the cabinet and vice versa. So yeah, very bizarre.
Interesting. I used to sleepwalk, but I don't think I ate in my sleep. But I grew out of that. The scariest thing. Okay. Pica we often see in little children. They eat non-food substances at not age appropriate times. So a lot of times dirt, sand, I think even ice sometimes, because there's no nutritional value in that. Baby powder. Now that one would be a hard one to try to eat, I would think. But yeah, can they? It's like my son, he will get the poop, Nestle Quick, and he'll scoop it in on his, on a spoon, and then he laughs, and then the hot chocolate or the cocoa powder comes out his nose. It's like a strange addiction. Yes. Oh, somebody ate her husband's ashes. Yuck. Well, yeah. Anyway, rumination disorder, repeat regurgitation with medical conditions that are ruled out, as well as not having anorexia or bulimia. Avoidant restrictive food intake is limited or selective intake of food. It's similar to anorexia, but it does not have the distress or concern over the body image or weight gain. And then you have unspecified feeding or eating disorders. It does not fit fully into any category, but there may be distress portion of it in their aspects of life. So they don't meet any of the other criteria, anorexia, bulimia, binge eating, or any of the other disorders mentioned on this place, but they do have some issues with eating and feeding. Okay. Things that are not in the DSM-5 are orthorexia. It's obsessed with eating healthy that interferes with their normal life. It often goes hand in hand with obsessive compulsive disorder. I believe you guys are going to go over OCD next semester. Compulsive exercise, which is somebody who does exercises. Wish you had that. Yeah, I don't have that either. Exercises so much that it actually interferes with other areas of their life. Like they have to do 900 push-ups, then they have to run and do all the other stuff. And I had a friend who did this often. Like she would always, I'm not judging anybody who wants to have a good, healthy workout habit, because God knows I don't. But she would just always be doing some kind of exercise, like all day and all night, and would limit a little bit of what they ate, but was very obsessed with, how they appeared. Laxative abuse can occur with individuals attempting to eliminate unwanted calories or to feel thin. All right. I'm just looking at our time. We got 15 minutes. Okay. Health promotion, we want to make sure that we identify early any negative concepts of self or self-esteem, and identify strategies in which we can help them promote a better self-confidence or self-esteem. Implement, since we are looking at this happening in your early teens or adolescent years, we want to make sure that the school is involved. Healthy screenings, we want to make sure we identify all of these manifestations, and they are properly diagnosed appropriately. Team approach, we're going to have a lot of different people working together to implement theory, some therapies and stuff. And I think you guys talked about that with support group and behavior modification, psychotherapy, family therapy, and this can impact the whole family, not just the person with the eating disorder. Okay. Recovery can be a lifelong process. It's a journey, just as we think about a person recovering from an addiction, or being overweight. We have to make lifestyle changes. This is something that they're going to struggle with probably throughout their life. We got to get down to the stem of or the root of all the problem that is causing that. Like you said, if there's any type of violence or things that have occurred, we want to get them help, and we want to make sure that they have a safety plan. If you're feeling unsafe or you're a risk to harm yourself, we want to make sure what to do, who to call, when to call them. We want to make sure that they have a good, strong support network. You will see that they have support groups for people with eating disorders, and they should attend them regularly, just as if we have a person who has an addiction to alcohol or substances abuse. We're going to make them, recommend AA, NA as well. So they do have those events. Reward milestones, whether big and small. Prepare for relapse, so they may have do very, very well, and then all of a sudden something happens in their life, a stressor, and brings them back, and they start doing it over again. A lot of times it's a way to feel a sense of control. Okay. These are just the stages of change and into recovery. You don't have to memorize them, but just know that these are the steps that they will have to go through. Our assessment is going to be important, making sure that our patients are safe. That's most critical, that they're not going to risk them, harming themselves. As we mentioned, suicide is common, so we want to make sure that they're not risk for physical injury, that they're not in risk of harm because of these electrolytes being off balance. Next, we want to make sure that we establish a therapeutic relationship. This is where we need to build trust with the patients and apply all of those principles of therapeutic communication that we talked about the first semester. And we want to be very tactful when we interview our patient. We want to try to avoid those non-therapeutic things or barriers to communication. Avoid asking personal questions that aren't necessary or won't provide us with the assessment data that we need. And again, this is where we don't want to ask those why questions or make them feel like they're being judged. You need to do a great, thorough physical assessment, your head to toe of your patient. They're going to be seen by medical providers. They may need more frequent medical conditions, especially when the times where their electrolytes are off. And that's when we may see that they are hospitalized. Another time when we may see that they're hospitalized is when they are at risk for hurting themselves, right? If they're at risk. So then we will see that these patients may not be necessarily having outpatient treatment, but they may be committed to a facility that specializes within feeding and eating disorders. It's important to check the vital signs, appearance, and assess for behavior. And I think we talked about that. Diagnostic test. You can also identify, just as we talked about our patients with failure to thrive, our patients with eating disorders. We're going to look at which kind of lab values. What do you think we want to? Albumin. There you go. Exactly, H&H, your anemia. So the lab value is not going to specifically say, oh, you have an eating disorder. Again, the diagnostic criteria is going to be based on the criteria in the DSM-5, but we are going to look and identify what kind of risk they are and how they are doing based on the lab results, okay? So here, diagnostic test goes over the albumin, total protein, electrolytes, your CBC, bone density, because as mentioned, they're going to have the dense, brittle bones. EKG is going to be done for your cardiac dysrhythmias. You want to look at kidney, thyroid, liver function test, and your analysis. And this is your image of your scarred teeth for your patients who are vomiting. Do you see how can you see my pointer? You see how it lost the outer protective coating on there and the dark spots as cavities? All right. So that's going to be with your specifically with your patients with bulimia nervosa or your purging. Lab tests may show electrolyte imbalances and dehydration. All right, binge eating is going to be the same, physical exam, blood, and blood and urine. All right. These steps are kind of the same thing that we talked about. What kind of interventions are we going to do? We need to make sure we have a therapeutic relationship with our patient. We need to help our patients with the eating disorders, the first and foremost thing is to provide a safe environment for them. Once we're safe, then we can focus in on more of the long-term management. As you know, therapies, the cognitive and all kinds of other behavioral isn't going to be immediate. These are things that take time for the patient to get better. All right. Considerations with children. You want to make sure that they're just not picky eaters. And they, these guys are refusing to eat. They limit their food. They have issues with texture, color, or smell. Typically is eating disorders typically are not being diagnosed fully by the pediatrician. And we're seeing now higher rates of young children and boys and children of minority groups that are starting to have an increase in the number of cases of eating and feeding disorders. Okay. Adolescents, as you can imagine, when you think about what they should, what are the steps through Erickson, what's going on in their life, they're trying to deal with a lot of adjustments, trying to fit in with other kids, or now they're starting to socialize with other people. They start to see things are different. They start go through, especially young women, their body starts to change. They have concerns about fitting in and wanting to look very thin, right? Common with sexual or physical abuse. And you can also see it too with children overweight as a child. I'm not sure what's happening here. Okay. All right. And adults can, it's not just limited to, teenagers or adolescents. You are going to see this in adults as well. And when we talked about, bariatric surgery, you may even see people with eating disorders often want to try to have the bariatric surgery as a way to lose weight. So that's a lot of time why you'll see a significant, amount of evaluations for mental health issues before somebody actually undergoes the bariatric surgery. Older adults, you're going to see, all the changes and things that we just talked about in failure to thrive. They can have that appearance as well. These are not, with the eating and feeding disorders in your elderly population. It is, not due as much due to, in order for it to be considered an eating and feeding disorder, it's not just because of the medication, the sensory, and all those other things that we talked about with the failure to thrive. Okay. What we will see and what's important in our older adults is that they may, if constantly have been purging or not eating, we're going to see that they have osteoporosis, cardiac problems, and a lot of reflux. Okay. It's very important to watch for eating and feeding disorders in a woman who is pregnant, because they may have a hard time with the weight gain, or being eating enough so the fetus can grow healthy. So a lot of times you may see that they may have a need for emergency C-sections. The baby may be preterm. Okay, and it puts the mother and the infant, or the unborn fetus at great risk. And a lot of times too, sometimes you will see pica that will develop in pregnancy. So you have these abnormal cravings of non-nutrient items. So that might be something else to watch out for. Okay. Consideration in men. You know, a lot of times people just stereotype or think that an eating disorder only occurs in female, as it does for the most of the time. But we cannot forget that, you know, this can also occur in men as well. They suffer from a history of you know, maybe sexual abuse. They may be bullied as a child when they were overweight. Their sexual orientation may play a role. Also have a history of depression, anxiety, hand in hand with other substance abuse. And the social and cultural pressures also play a role. Okay. Assessment. We want to do a good, thorough assessment. We want to height, weight, BMI. We want to ask them questions about their eating patterns. We want to do a good assessment of their nutritional status. What is it that they're eating? How many calories are they taking in a day? We want to focus in on how much exercise they are doing and look at what their perception is of themselves overall. Okay. We know, you know, by now you guys know what a therapeutic relationship is, but we need to make sure we, you know, provide a relationship, you know, or build a relationship out of trust. Allow the person to feel that we're not being judgmental with them. Allow them to, you know, speak about how they feel. We want to let them have a sense of control over themselves. And we want to encourage them to be able to reconnect with things and people that they once used to enjoy. All right, collaboration. We're going to work with a lot of different people. We're going to, you know, talk about medication management. Again, we have a history of anxiety and depression, so we will be using those antidepressant medication. We're going to refer them for counseling, and then the cognitive behavior. Okay, we want to make sure that we are going to work to have them, you know, eat properly, stop the binging and purging, and make sure that the exercise is at an appropriate level if they're excessively exercising. A lot of this collaboration is going to happen on the outside, but, you know, again, anybody who is critically ill with severe malnutrition or severely underweight is going to be those patients that we are going to see in the hospital unit. And a lot of times when we're taking care of the patients, they have an eating disorder. That might not be the primary reason why they are hospitalized. You know, as body systems start to, you know, to fail, your kidneys or you know, heart, or develop heart failure, that's what we're going to be treating them for. Okay, we talked about the pharmacological, non-pharmacological. Got that. It's just brought in here again. And then contemporary approach. Think, you know, you may see that therapy can help to reduce anxiety, acupuncture, massage, yoga, meditation, anything to help you know, decrease a person's stress level, improve their mood may be helpful. Okay. Any questions about the difference between the three big type of eating disorders? I would say make sure you focus in on those three: the anorexia, the bulimia, and the binge purging. Those are things you want to know. You want to know how they are going to present, what is the criteria, and some interventions about how we are going to treat them. Things that we talked about that.
I got a quick question. So binging and purging is kind of separate then from bulimia, correct?
Correct. Yes. They're two different. Let me go back.
Okay.
So um you're talking about the binge and purge, right? So
Yes.
okay. With the bulimia nervosa, they are eating a lot of food and then purging after, right? Because they feel a sense of guilt, or it's a way that they can, kind of feel control. They might also diet and exercise. With the binge eating disorder, they are going to be eating a lot of food there. They aren't necessarily going to be doing those compensatory behaviors, such as the vomiting. So with binge eating, they're just eating a lot of food because they feel like a lack of control, and they're not, they are feeling full already. They're sneaking around, and they're not necessarily hungry. They're just eating.
Okay, so that it doesn't necessarily mean then that they purge either, right? You said?
Right.
Okay.
Binge eating episodes is just binging. They're eating a lot of food. It's just because they're feeling guilty about it, it's not followed up with the vomiting or,
Okay, yeah, no, that makes sense.
make sense?
Yep, perfect. Thank you.
You're welcome. For Friday, yeah, it will be Friday. I'm going to try to be available like 1:45, 2:00 ish to make sure people can get home from clinical if they have clinical. Anybody who has clinical all day on Friday, I may have time if you want to reach out to me on Monday after I have a NSNA meeting that I have to attend from 1:15 to about 2:30. Okay. Bye-bye.